Hi, everyone. Welcome to the Sports Docs podcast. On each episode, we chat about the most recent advancements in the field of sports medicine with experts from around the country. Today, we're coming to you live from the 10th annual Arthrex Team Physician Controversies Conference in Naples, Florida. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan. The Team Physician Controversies course is a 2-day event where we speak with experts from around the world who are working in both professional and collegiate sports to discuss case-based discussions and presentations. We're fortunate enough to meet with a lot of these leaders and experts today to discuss cutting-edge sports medicine.
We are joined today by Dr. Travis Maak, an orthopedic surgeon who specializes in sports-related injuries of the hip and knee, with a particular focus on cartilage restoration and joint preservation. He is an associate professor of orthopedic surgery at the University of Utah, head orthopedic team physician for the Utah Jazz, and team physician for the University of Utah Athletics. Dr. Maak, welcome to the show.
Thank you for having me.
Yeah, we're excited to have you. So today we're going to be diving into knee cartilage disease. We're going to talk about diagnostic workup. We're going to be talking about decision-making clinically, as well as options for cartilage restoration. Specifically, we're going to focus on a few cutting-edge things. So Autocart, BioCartilage, and Cartiform.
So before we get into the fun stuff, let's start at the beginning with our diagnostic workup. So you have a patient with activity-related pain, intermittent effusions, maybe mechanical symptoms suspicious for a cartilage defect. So what does your workup look like? What imaging are you getting and what are you looking for?
Sure. I mean, we all sort of start with the basic x-rays. We, at least within my practice, we typically do a 4 series. So your standard AP, flexion, and then your lateral and merchant or sunrise, depending on which way you want to go with it. After that, bone trumps all, in my opinion. Alignment trumps all. So you're taught early on in residency and fellowship, as you all know well, that ultimately you have to get alignment views when you're talking about cartilage, whether that be lateral or AP alignment views. For us, in this case, with a knee especially, it's going to be AP alignment joint survey. So that's a absolute staple for me. If you don't fix alignment, nothing you do from a soft tissue standpoint is going to work. So a lot of times I teach my residents and fellows that as well. So they all get alignment views. We make sure their alignment's appropriate. After that, standard MRI. There you can go into a lot of different types, 1.5, 3 Tesla, candidly. And then there's the cartilage-specific imaging. But to be totally candid, we just standardly do a 1.5 Tesla MRI. And I don't really see a big benefit in doing the others. 3 Tesla, if we have the option to do so. But a lot of times patients will come in with an MRI. And just for insurance purposes, we're not going to repeat it for cost prohibitive problems.
Yeah, absolutely. A lot of great points. And as you indicated, alignment is a big issue. Meniscal deficiency can be an issue as far as failure as well as instability. So in addition to that, there's maybe some patient factors, whether it's the size of the defect or, BMI or, other activity level, age, all these types of things. So as far as deciding the optimal treatment for your patient, how do all the patient factors fit in?
That's a tough one. You're leading the witness to some degree.
We try.
Yeah, which I appreciate, honestly. So I will say that ultimately, to your point, patient factors are probably more important than any sort of imaging.
Sure.
You have body habitus is a big one, of course. Age is a big one. The older I get, the younger my patients are, and therefore the more active I think they are in my own head. I remember in my early 30s, wow, you're 46. I don't know if you're going to make it. Now I'm 46. I'm like, oof, you are young when you're 46. So it's a little bit different, and we apply our personal biases, I think, from time to time. But to your point, cartilage transplants and meniscal preservation generally, in my opinion, is and I use this term loosely as I referenced, a young person issue. And I usually define that as around 50 or below, candidly. But I think body habitus, to your point, is a big one. We know that cartilage, meniscal transplants, things like that don't work well if your BMI is really 30, 35 or more. The lower, the better, candidly. And that's not to say they can't ever get it if a patient has a larger BMI, but it is a conversation that I have with them and talk to them about nutrition and bringing down their BMI to a level that we have better outcomes. And I think the data would support that. Gender, of course, obviously is one, although I know there are papers that suggest that sometimes men do better than women, sometimes women do better than men. But as far as I can read the tea leaves, it doesn't actually matter. So I sort of put that out of my thought process, accepting the fact that women are generally more genu-valgum. So the alignment plays a role from a gender standpoint, but otherwise I don't really think about it much.
Absolutely.
Yeah, that's a great overview of the different factors. We're not just looking at defect size and location and containment. We're really considering those patient factors. So now let's shift our discussion to some of the newer cartilage restoration options that we want to discuss today, starting with Autocart. So what is Autocart and what is its appeal versus other cartilage treatments that are available?
Sure. So I jumped into Autocart out of necessity, candidly. It wasn't called Autocart back then, but it was something that Arthrex gave as an opportunity for us, frankly, from an innovation standpoint, to treat things that we couldn't treat before. I started using it in the hip, oddly enough, only because there were cartilage defects in the acetabulum that were just not able to be treated arthroscopically. And then as a result, we had to do a surgical dislocation, which is a really morbid procedure. And I said that there has to be a better way than this. This is an absolute disaster having to do this to patients. So we kind of worked with the folks here that were amazingly helpful in that regard to harvest the cartilage from the femoral head, which we effectively remove anyway at the time of the osteochondroplasty, but instead to harvest it. And they developed GraftNet to do that, which GraftNet, just as I'm sure you all know, but it's effectively a very simple but fascinating device that sort of attaches to your shaver, and it captures the cartilage as you're removing it in a very simple fashion. I'm not a particularly good surgeon, so they have to give me instruments that make me look good, and that is one of them. So it catches all the cartilage, and then you can use that on the back table, and it's harvesting the patient's own biology. Admittedly, I did it without a lot of evidence to support it at the time, and that's not usually the way I approach things. I work in academic medicine, so for me, evidence is king. So I figured I needed to put some data to that. So we harvested the cartilage, and then we combined it with, at that point, whole blood, because it really was sort of a bobbing and weaving such a scenario in the OR, to be totally candid with you, and then transplanted it back in. And again, prior to thrombinator, we actually just used vibrant glue and sort of glued it in, and I crossed my fingers because I didn't know what else to do. And the patient did really well. So Autocart, to give you an overview, is basically harvesting the patient's own cartilage from areas they don't typically need it. For me in the hip, it's on the femoral head-neck junction, where the cam deformity is, but you can also do it in the knee, where you guys know very well, where you used to take Oates plugs, so right in the notch or the far peritrochlear zones, and you harvest it, and then you transplant it back in, and it's effectively a cellular scaffold, and it does incredibly well. So that's Autocart, and I now use it to treat very difficult lesions in the trochlea and on the tibia and the acetabulum, just areas where it's really hard to get anything else there.
That's great.
Yeah, I think super helpful and obviously a nice biologic advantage. Our listeners always really want to do a deep dive into technique like pearls. So as far as defect preparation or delivering the cells in, can you tell us a little bit more, Travis?
Of course. Ultimately, there are a lot of ways to skin this cat. And I know there are a lot of papers out there that talk about, do you poke holes? Do you do microfracture? Do you marrow stimulation? Do you just scrape the cartilage? Do you need to remove the calcified cartilage later, et cetera? So I'll tell you what I do. And thus far, it has been worked fairly well, and the data supported it. So for me, I remove the calcified cartilage layer. I use a curette or a ring curette to do that. I try to minimize bleeding, although I do think the power pick has changed that a little bit. Because it doesn't create a true microfracture propagation. That's something I've tried to avoid. And we have very good data to support that cellular scaffolds, whether it be any type of cellular scaffold on top of a microfracture, doesn't do well. So marrow stimulation changes that. So I do use marrow stimulation now. I used to not. Now I do with the advent of the power pick, which is an amazing facility that allows us to do a very quick and easy marrow stimulation drilling that does not propagate fractures. Over the top of that, I then take the Autocart, which is the patient's own cartilage. It's prepared on the back table by my scrub tech at the time. She's very good at it at this point, better than I am, frankly. And then we use the patient's own biology, and you can use whatever particular cocktail you want. I typically use PRP to be and BMAC, to be honest with you, and then thrombinator to basically keep it, once it's implanted, keep it there. And then I arrange the knee. It's done under a dry scope at that point. So that's a really important point. Obviously, putting this stuff under a wet scope, having done it, does not work well. It floats around the joint and disappears, and then you get really angry. So dry scope, put the cells in, and then put the thrombinator over the top, wait about 2 minutes, and then you can put the water back on and range the knee or the hip in this case, and it works great.
Great. So that sounds very similar to other cell-based procedures we have, but with the benefit of using the patient's own cells and, most importantly, a single-stage procedure, which is really huge for patients, I think. Now, you went through the technique. No water is a pearl. Any other pearls or pitfalls that you've come across when you started adopting this procedure for surgeons that are thinking about adding this to their repertoire?
Sure. Everything that is a disaster, I can tell you, has happened to me. So I'll try to save others from my own folly. In the knee, a lot of these tibial lesions occur laterally. So one thing that I noticed not thinking about it, and you guys can forgive or feel free to judge, I probably should have, but
No judgment
you put the knee in a figure 4, which we all do in a standard practice, and then you implant the cells. What I didn't think about though is at that point, the tibia is basically vertical to the ground. So water drops down. Yeah. So I put the cells in, and that was great because it's basically a putty. So it goes where it needs to go. And then you drip the thrombinator and it drips right down to the lateral side of the knee, not where you want it to be. So little pearl there. Don't do that because you suck out the thrombinator and it takes the cells with it. And that's not great either. So when you do it, just take the knee out of a figure 4 and just lift up the thigh a little bit. So now gravity helps you and it distributes over the tibial plateau normally. That's the first one. In the hip, same story. It will drip into the bottom of the acetabulum. So and it's really hard to keep the hip dry. So putting a spinal needle through the posterior portal and then attaching it to suction. And you can do this anywhere, by the way. Rather than using a shaver to dry things out, you just drop in a spinal needle and stick your suction on the spinal needle cannula. And it keeps everything dry. You put it wherever you want. And then you can drip the stuff in and it takes away all the excess out very simply. So those are the 2 things that I've learned that have made my life a lot easier.
That's great. Thank you.
Yep.
I mean, that's the stuff, right?
Yes,
It's,
that's what our listeners
these
want.
little learning pearls. That's what we're all here for.
Yes.
So now let's talk about how do these patients do? So as far as who, even if you're sort of saying this sort of demographic, this lesion location, who does well and why, do you think?
So we know diffuse articular cartilage injury is more going down the arthritic pathway than it is a focal chondral defect.
Sure.
So I think in general, cartilage transplantation, as you both know very well, does better if you have a focal chondral defect.
Yes.
I tell my patients, it's a pothole in a road. You can fix a pothole. If the whole road's falling apart, like fixing a pothole doesn't solve the road in any way. You just need a new road. So I use an ice analogy, and it works really well for my patients. The reason I'll share it with you. I've had a hard time explaining cartilage to patients. They know 2 things. One is bone-on-bone arthritis, which I've learned is everybody. If you just talk to a radiologist, they're all told they have bone-on-bone arthritis. And then there are the people who have no problems, and then they have the ones that we actually treat. So the anecdote I use, which has worked really well, is an ice rink. So I ask all my patients, you ever skated on an ice rink? Some people say no, and that shocks me. Or at least, and then I'll say, well, have you ever seen a hockey game? Let's go down. So you finally get them to say yes. And then at that point, I tell them that you don't actually skate on an ice rink. You skate on ice. The ice is placed on the ice rink. Ice rinks are concrete. So the ice is the cartilage, the ice rink's the bone. And if you ice skate over a long time, your ice goes away. The Zambonis, when you're born, you don't get another Zamboni, by the way. So we can fill a hole in the ice, but we can't fix a broken ice rink. So at the end of the day, that's what we're doing. And then I show them an MRI and I say, here's your concrete, this is the bone, and here's your ice, this is the cartilage. You have a pothole in your cartilage, so we can fill the ice. And then I tell them how, using sinkholes and other analogies underneath the ice rink. So that's OCD. So long story short, to get to your point, who do I think does well? The focal chondral defect, so the pothole in the ice. Young individuals, generally speaking, that are not good candidates for arthroplasty of any sort. I actually love it when they have malalignment, because if they have a bigger problem, then we have a better solution. So if it is in combination with an osteotomy, I know they're going to do well. I worry about meniscal deficiency because meniscal transplants, even if done in the best of hands, are, in my experience, very difficult to predict whether they're going to do well or not. So I'd love when they don't have meniscal insufficiency, but if they do, you need to treat that too. So ideally, relatively thin body habitus. I use thin in a very general fashion, by the way. It's not an aesthetic issue. It's simply a BMI under 30, 25, somewhere in that zone. That's for me thin, by the way. And then basically active people that want to go back to do their sports, and they all fairly do well as long as it's not a bipolar lesion, and that's a key too. So if you have damage both on the femur and the tibia, or the femur and the acetabulum and the hip or other joints, bipolar lesions are tough. And I have to say I have treated some in very elite Olympic and professional athletes because they're 19. And at the end of the day, what else are you going to do? But you need to do a comprehensive workup there, make sure it's not systemic, make sure it's not a rheumatologic issue, and that this is a focal defect that resulted as a result of their high level athletics.
Yeah, great advice.
Yes,
and I have to say, though, as someone who puts an ice rink in their backyard every year, I look at it very differently now.
Yep. Exactly.
Use that now. That's a great analogy. So it sounds like Autocart's a really excellent autograft option for our patients, as you said, with focal cartilage defects. So now let's switch gears and talk about single-stage allograft options, starting with BioCartilage. So can you explain what BioCartilage is and how does it work?
Sure. Before I do that, I'm not going to off-road you, I promise you. The one thing I did want to say on Autocart and the single stage, in keeping with the BioCartilage concept, at least in the hip especially, it's less common in the knee, but it occurs. Sometimes you're in the knee and you didn't know it's there. It happens in the hip a lot because of the congruency of the joint, less so in the knee because it's not as congruent. Having said that, it does happen. And then you have a focal chondral defect that you're not sure what to do with. And you think it's something that should be treated. Now, taking an Oates plug and transplanting in an open fashion with something that you haven't really explained to the patient in advance, hard to do. Autocart, a different story. Because a lot of times, especially with an ACL, you're going to take down part of the notch anyway. You're going to sacrifice it anyway. You're really not adding any additional problem. The only thing you're adding is potentially a different recovery. We can talk about rehab later, but it gives you an opportunity to have something we've never had before, which is the oopsie save, which happens to me frequently.
Great point.
So on the BioCartilage, so BioCartilage is amazing. It's effectively extracellular matrix that, again, an amazing Arthrex product that I actually combine with Autocart whenever I do it. And for two reasons, actually. One, it brings in a scaffold that allows the patient's own cartilage to proliferate. And we have very good data to support that the viability goes up when you do that. The second thing it does is it frankly makes it surgically easier. So little chips of cartilage are hard to deal with. Actually, they fall all over the place, as you guys probably know. If you add it with BioCartilage, now you have a paste, and you can stick paste anywhere, and it sticks. So it's just surgically easier, but it also brings in the biology. And we all know it's better with bio.
Yeah, absolutely. So we already talked a little bit about indications. And so we're going to assume you know that there's some sort of defect or lesion going in. What's your decision-making as far as these two that we've already discussed?
Size is the biggest one. Location is the second one. So at the end of the day, you can't harvest all the patient's cartilage throughout their knee and stick it somewhere else. That's not going to work out well. So it's a size-based decision. For me, generally speaking, if it's 2 centimeters squared, that's usually where I start to limit Autocart. In the trochlea, I do expand that a little bit only because of the morbidity of a trochlear osteochondral allograft transplant, and the convexity, or in this case, concavity, can be hard to match. So cellular-based scaffolds work better. But generally 2 centimeters squared, I'm using Autocart. On the tibia, I almost always use Autocart, actually, just because we don't have a lot of other options available to us currently. And then past that, I'm going more to an osteochondral allograft transplant or something of that nature, Cartiform as well, that just expand the size. But generally 2 centimeters squared or less, that's for me, Autocart.
Okay. That's great. It sounds like it's the perfect kind of middle ground for if it's like too big for maybe a standard microfracture and too small for some of those bigger procedures, or those procedures are too morbid. Now, we want to talk through the surgical technique. You mentioned that you combine BioCartilage with Autocart, but are there any differences in your BioCartilage approach in terms of surgical technique, preparation, any pearls to offer our listeners?
Isolated BioCartilage, you mean? I almost never do that anymore, to be totally honest with you.
Yes.
The reason is there's always an area where you can harvest the patient's own biology. And BioCartilage was really helpful early on and still is, but I don't see any reason to not use the patient's own biology.
That makes sense.
So I can't remember the last time I used BioCartilage in isolation. Now I combine it with the patient's own biology, and it's an Autocart BioCartilage combination.
That's great. And as far as outcomes, before you started doing that, what are some of the differences that you see?
So you mean BioCartilage in isolation? So the outcomes were better than marrow stimulation. You mentioned microfracture. I don't do microfracture anymore. I haven't probably in about a decade, honestly. The only reason being we're all sort of informed by our own folly, I think. And I had some patients that I did microfracture early on in my career, as I'm sure you all did too. And they just didn't do as well. It's a really painful procedure. Then they get overgrowth osteophytes. Right. And the only way you can salvage it is with a transplant. There are no other choices. So now I use marrow stimulation with the smaller lesions, to your point, and that doesn't have that overgrowth. But so marrow stimulation plus BioCartilage does better than marrow stimulation alone. It just, again, brings in the scaffold, keeps those bone marrow elements in the same place. It applies effectively a nice little layer over the top so the marrow elements aren't just getting washed out. So the outcomes are better. The fit and fill is better. And we know that fill with cartilage after a marrow stimulation, the quality and quantity of fill is always going to be correlating with outcomes.
Absolutely. So now let's shift to our final discussion today, which is Cartiform. So Cartiform is similar to BioCartilage in that it's a single stage allograft solution, but it differs in terms of structure and cell viability. So can you talk about that a little bit more?
Sure. So Cartiform is technically an osteochondral allograft transplant. So it has a very thin layer of bone attached to the cartilage. So it's a true osteochondral allograft transplant, but it's malleable. So it works really well, as both of you know, in terms of difficult to treat locations. So if any of the listeners have ever done an osteochondral allograft transplant to the trochlea, you know very quickly, no matter how good you are, it still doesn't look good when you're done. And then you're contouring it with a scalpel and hoping it's going to be okay. So Cartiform gives you an opportunity to make it perfect every time because you effectively contour it to the patient's own anatomy. It's no longer a matching. You can just push it down, you sew it in, and it's a true osteochondral allograft transplant. You mentioned single stage, and that's an important point. Which is it's on the shelf, but these are viable chondrocytes and the data supports that. So for me, that's a larger lesion. So not the 2 centimeter squared Autocart, you're getting past that. That's where Cartiform becomes amazing. And the trochlea is a perfect option for it.
Absolutely.
Yeah. And, you started to talk a little bit about location. And as far as technique, are we doing this all arthroscopically? Is there a mini arthrotomy, or dive a little bit into that for us?
So Autocart for me is arthroscopic in all cases. Cartiform not. That for me is going to be done open, only because you have to sew it in. I suppose someone more technically appropriate and maybe better than I am, which many people would be able to do it arthroscopically. But for me, I want to get the anchors in perfectly perpendicular to the bone. And this is something I'm going to go to mat. At this point, we're going to the mat to the patient. I feel like I can do it better through an arthrotomy. It's a mini arthrotomy, but for me, Cartiform's done open. The remainder are done arthroscopically. BioCartilage, Autocart, et cetera. That's an all-in arthroscopic procedure, and that's the benefit in the hip as well.
So it sounds like Cartiform's a really great option for, as you said, those lesions that are a little bit too big, but patients don't want any more than a single stage procedure and off the shelf. So if you happen to see it at the time. Now, how do patients do after Cartiform in terms of pain relief, function, ability to get back to their sports?
They do great. I liken it to the osteochondral allograft transplant, to be honest. It's effectively the same thing with the benefits of you don't have to wait for a graft match. You don't have to stick a patient in your operating room and you don't have time because of graft match and everyone's scrambling. And similarly, the patient doesn't have to fly in from somewhere else in 2 days or drop everything. So it's a very easy transplant to do, and it has the outcomes that are basically identical to an osteochondral allograft transplant, which, as we know, they're incredibly good with outcomes, 20, 30-year recovery being perfect integration.
That's great.
And before we finish up, we always love to hit on rehab and recovery. So out of the 3 we've talked about, how does the recovery differ?
Depends on what the lesion is, as you know. So if it's a weight-bearing region, meaning we'll use the knee as an example. So tibia or distal femur, they're going to be toe touch weight-bearing for me for about 4 weeks, and then I transition them off by 6. Trochlea is different, patella is different. I let them weight bear as tolerated, locked in extension because it doesn't load the patellofemoral joint, which sounds like a very minimal difference, but it makes people way happier.
Absolutely.
When they can walk around without crutches, it's night and day different. I let them range immediately. Stiff knees are unhappy knees. So no matter where I do it, whether it be Autocart, BioCartilage, Cartiform, doesn't matter to me. They range immediately. I want them to get their range of motion back. And I tell patients, straight first, bent second, strong third in that order. And I communicate that to the physical therapist as well. So I don't know how you all are, and I don't know how the listeners are, but I'm very particular with my PT, probably overly particular, actually.
Same.
Only because there's a lot of variability, and physical therapists make us look good or make us look bad. And I think that if they move on to strength training, stimulation, et cetera, before the patient has their range of motion back, they're just going to be fighting this horrible pendulum, and the patients swell and are unhappy.
I will say, our listeners know this because we talk about it all the time. I was a physical therapist for 7 years before med school, so I'm very particular. And I will say that most physical therapists are they appreciate that, because the worst thing you can get as a PT, and I used to get these all the time, is a script that just says eval and treat, and you get those more than you'd think.
Yep.
So
yeah, absolutely. Proper rehab is critical to getting people back.
Totally agree.
Well, thank you so much for joining us today. This has been a very insightful discussion. We really appreciate it.
Yeah, no, we loved having you on. Very insightful, and we appreciate you sharing all your expertise.
I appreciate the opportunity. Thank you both.
And thank you for listening to this episode of the Sports Docs live from the Arthrex Team Physician Controversy Conference. We hope you enjoyed our discussions today as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and YouTube to stay up to date on all things sports medicine.